Hello, this is Dr. Bhomik. Welcome to my YouTube academic channel. And so far I have posted more than 33 pediatric endocrine lectures and more will be submitted. But I have decided to break the monotony a little bit. I am now going to present a series of very interesting and the rare cases that we have seen in our pediatric endocrine clinic. And most of the cases were referred to us, and today I am going to discuss with you a very interesting case of a 9-year-old Asian American who was seen in pediatrician's office 2-3 times before he was referred to us. And so his evaluation, diagnosis and differential diagnosis will be discussed at this presentation. And this was in our university hospital, a 9-year-old boy with gross intermittent and sometimes with macroscopic hematuria as well. So my goal is to present a case of prepubertal boy with persistent intermittent hematuria, and we'll discuss the workup that led to the diagnosis of this rare condition in pediatrics, discuss the leading cause of hypercalcemia in children, and we'll discuss the management and the follow-up of this patient. So case history, this was a 9 years 4 months old boy who was presented with gross but painless hematuria, and this has been intermittent for the period of 5 to 6 month duration, and presented to the pediatrician's office. The initial workup was not that complete, but when third time pediatric visit, when they did discuss the intermittent hematuria, history was referred to the endocrine clinic. And the hematuria usually occurs after a soccer game. He was very active in his sports, and the soccer was his favorite sport. After a soccer game, the gross hematuria will persist for 4 to 6 hours, and according to mother, that after that urine will clear. There is no history of weight loss, polyuria, polydipsia, no history of chronic kidney disease or urinary tract infection. And the physical examination, he is a healthy child. It's a normal physical examination otherwise. And his height is at 10th percentile and weight is at 5th percentile. So he did a little bit skinny side. His serial blood pressure measurement that was done in pediatrician's office as well as in our hospital was within normal range. There is no evidence of pubertal development, and so he was admitted to the hospital, and the following laboratory evaluation was done. His microscopic hematuria was evident without any exercise. It was 50 to 10 RBC per high power film. Urine culture was negative ×2. He has normal blood count, thyroid function, adrenal function, electrolyte, BUN, creatinine, as well as the liver function test. Serum calcium was done in quite a few occasions, and I have put some here. And and it shows that he has persistent hypercalcemia. We also did the ionized calcium, which also was persistently high. Serum phosphate, on the other hand, was low, 2.8, 3.1, and 3 milligram per dl, and the normal level is clearly more than 3.5 to 6 to 5.5. Other laboratory evaluation shows he has got normal gastrin, calcitonin, 24 hours urinary VMA catecholamine was normal, and we did a random urine for calcium creatinine ratio. In 2 occasions, it was significantly high, was 0.35 and 0.32, and the reference is in the bracket. 24 hours urinary calcium was 136. Compared to his body weight, it is extremely high as well. 25 hydroxyvitamin D was low normal in 20s, and his intact PTH was 90.7, 101.98, and the reference is between 10 to 60. So the diagnosis clinically was established as primary hyperparathyroidism, and that was based on persistently elevated total and ionized calcium, persistently low phosphate, as well as low normal vitamin D3, no normal vitamin D level, as well as persistently high PTH level and hypercalciuria. So these are the classical laboratory criteria to make a diagnosis of primary hyperparathyroidism. So the differential diagnosis I am not going to discuss because in my causes of hypercalcemia in pediatric age group, a complete lecture is submitted in this YouTube channel, and it is rather comprehensive, and I would request you to read those, and that will discuss all the differential diagnoses that I have put here. Williams syndrome, familial benign hypocalciuric hypercalcemia, hypervitaminosis D, food faddism, and a chronic granulomatous disease, and hypercalcemia of malignancy. And therefore, radiological evaluation was the next step, and it clearly hand film was questionable osteoporotic of the disease. Renal sonogram was normal. Neck sonogram was also negative. Dual thallium technician digital subtraction scan, as well as the neck system scan, was unremarkable and questionable. There was a difference of the opinion among the radiologists, and some of them felt that there is a possibly an lesion, adenomatous lesion in the right upper parathyroid, but two other radiologists was not sure. So next step, the patient was taken to the surgery for cervical exploration, and sure enough found to have a right single superior parathyroid adenoma. And right here at the tip of the forceps, this adenoma, which measure about 200 milligram nodule and 9 by 6 by 4 millimeter. So arrow is on the capsule, and inside the capsule, as you can identify the cell. In higher magnification, you can see these cells, and the arrow is on ectopic parenchyma. This is the large polygonal uniform sheep cells, which we one find in benign adenoma. So we are looking about the incidence of primary hyperparathyroidism. In adult, it's pretty much well established. It's about 20 to 30 cases per 100,000. But in pediatrics, it's very rare. There is a sporadic case report, and very rare, less than 16, but even more rare in a prepubertal age group, which we'll discuss a little bit more. And as I said, is a prepubertal age is very uncommon. The adult is clearly a female preponderance, 3 to 1. In pediatrics, the data is a little bit controversial. In some series, it is pretty same, and some series, the female preponderance, but in average, it appears to be 3 to 2 if you consider all the series together. The clinical presentation in adult, with the advent of more or less any physical examination, the patient usually get a chemistry profile. Adult patient, many a time they are actually detected by chemistry profile. However, they could present with the other symptoms, but children appears to be usually symptomatic. They may have polyuria, weight loss, poor appetite, non-specific abdominal pain, gross or microscopic hematuria, nephrocalcinosis, etc. Bone demineralization, fracture, and the cyst, especially if the condition is advanced. Primary hyperparathyroidism is only account for 1% of all hypercalcemia in children. So primary hyperparathyroidism only constitute 1% or less of hypercalcemia in children. Therefore, there are many more causes of hypercalcemia before you make this diagnosis. However, good thing is the diagnostic criteria is very straightforward. The treatment is a cervical exploration with or without preoperative localization. However, with the present technique of scan and the systemic scan, the preoperative location or is localization is pretty good, almost in some cities close to 100%. However, if the blood chemistry suggests it is a primary hyperparathyroidism, one should go ahead with cervical exploration. 95% success without preoperative localization, and system B and technician can, as I mentioned, that identify vast majority of the cases. And when possible, the visualization of all four parathyroid glands is necessary. So in conclusion, our patient has convincing lab finding, and preoperative localization was inconclusive, and system is scanned with a new one. This was done about 15 years ago. New would have been much better choice, and cervical exploration revealed the right side parathyroid adenoma. Patient had normal parathyroid hormone 2 months after surgery, complete, and we had follow-up after 2 years after surgery, and everything has been within normal range. So therefore, the literature review that I have seen, and I found mostly sporadic case report. Only there is a Turkish archive of children. They did a 10 years study from age 210 to 220. This is a retrospective study, and they found total 8 cases of children with parathyroid, primary hyperparathyroidism. All of their parathyroid was a single parathyroid adenoma, excepting one which was ectopic and was seen in mediastinum. There was one case report, and that was in 2023 in endocrine journal, which had a case of a parathyroid adenoma, happens to be in pyriform sinus, persistent sinus, parathyroid sinus that we see, especially in the patient who had recurrent parathyroid abscess. So that is very uncommon. And I will put those references in my YouTube information channel. So you can go and look further. But apart from that, it was all a kind of sporadic one case. But most of the case was after puberty, but there are some prepubertal cases reported in the literature. So the high index of suspicion is necessary. We as a pediatrician we see lots of cases, children with hematuria, and there are lots of causes of hematuria, but once in a while that some of them are going to be interesting, just like a parathyroid adenoma that we have discussed here. After the publication, after our report was published in a case report, and it also presented in the regional pediatric conference, which was sponsored by University of Mississippi in 1918. And after that, we had another case of parathyroid adenoma, and this patient was 16 years of age. So again, as the saying goes, that what mind does not know, eyes do not see. And so I decided to present this one because this is uncommon, but not extremely uncommon. So therefore, high index of suspicion is necessary. And thank you very much.